Hi, my name is Gabby. I'm a registered nurse and I'm here to hand over this patient to you. This patient is Mr. John Smith, aged 67. He is retired and resides in the eastern suburbs of Melbourne with his wife. John presented to the emergency department via ambulance at 6 a.m. with complaints of acute onset intense pressure and tightness in his chest, with pain radiating down his left arm and up the left side of his neck. He alerted his wife and they immediately called the ambulance. On admission, he was suffering symptoms of lightheadedness, shortness of breath, nausea, and was cool, pale, and sweating. His vital signs were abnormal, and his initial ECG depicted ST segment elevation. His background includes a history of high cholesterol, stage 1 hypertension. He smokes half a packet of cigarettes a day and has a family history of MI, with his father dying of a myocardial infarction aged 64. It is presumed that Mr. Smith is suffering from an ST segment elevation myocardial infarction. To confirm this, we recommend undertaking a full blood test with emphasis on troponin, CKMB, and serum lipid levels. Additionally, a repeat 12-lead ECG to note any changes, and then continuous 3-lead ECG monitoring, a coronary angiogram and an X-ray to determine if and where a blockage is. Acute coronary syndrome is an umbrella term that encompasses unstable angina, non-ST segment elevation myocardial infarction, non-STEMI, and ST segment elevation myocardial infarction, STEMI, and is among the leading causes of death in Australia. The three clinical categories are distinguishable through ECG readings and differences in cardiac biomarkers. Non-STEMI is primarily distinguishable from unstable angina due to the presence of elevated troponin and CKMB levels in the blood. STEMI is distinguishable from non-STEMI, as the name suggests, through the presence of an ST segment elevation in the ECG readings. John Smith's ECG, performed in the ambulance and on arrival in the emergency department, showed ST segment elevation. This, along with his past history, physical examination, and elevated cardiac biomarkers, are the reason he was diagnosed with STEMI. STEMI is caused when the demand for myocardial oxygen is greater than the supply of myocardial oxygen, and this deficit in supply is usually the result of coronary artery obstruction. Coronary artery obstruction is caused by coronary atherosclerosis, being the atypical buildup of lipid substances and fibrous tissue on the walls of the coronary arteries. This narrows the path of blood through the heart, through the vessels to the heart. Atherosclerotic plaque can form gradually over many years before angina presents, beginning as fatty streaks in the innermost layer of the artery. This progression of these streaks is most dependent on genetic and environmental factors. John's smoking habits, high cholesterol, and hypertension are modifiable risks, and his family history, gender, and increasing age are non-modifiable risks that likely contributed to the accumulation of atherosclerotic plaque in his coronary arteries. Until now, the accumulation of plaque remains relatively asymptomatic. However, the events of a myocardial infarction are precipitated if there is a rupture of the plaque. The rupture encourages the accumulation of blood cells and platelets to the damaged area, forming blood clots or thrombus. If the blood clot becomes large enough, it can significantly interfere with the flow of blood through the vessel, hindering its ability to form contractile work. This reduces the supply of oxygen and nutrients to the heart and the removal of carbon dioxide, which begins to cause extreme and irreversible damage. Clearing the blockage in the arteries is the first priority for John's treatment, in an attempt to save as much of the heart tissue as possible. This is called percutaneous coronary intervention, or PCI. To clear the blockage, John would be referred to a cardiac catheterization lab in the hospital, something which most developed hospitals have. Here, he would undergo a cardiac angiogram used to find blockages by injecting dye into the arteries through a catheter, making them visible on X-rays. Once the blockage is found, a small balloon is moved to the site and inflated. This presses plaque on the artery walls, creating a space for the blood to flow through. To maintain this opening, a stent, a small expandable tube, will be permanently inserted into the site to maintain the opening and prevent further occlusion. The goal for patients like John is to move them from entering the hospital to inflation of the balloon within 90 minutes. If a hospital does not have a cardiac cath lab, the use of thrombolytics can also be initiated in an attempt to clear the artery. Possible complications during PCI can include puncturing, sudden blockage or sudden constriction of the coronary artery, development of an irregular or abnormal heart rhythm, and cardiac arrest. These may need to be dealt with by emergency surgery. Post-PCI complications may also include sudden closure of the artery, bruising or bleeding at the initial site, hematoma, blood clot, or kidney injury. Secondly, infection of the stent implanted in John's artery, marked by symptoms of fever, chest pain, and positive blood cultures, could present as another complication. Although this is very rare, it carries a high mortality rate and needs to be carefully monitored. Finally, if the atherosclerotic plaque blockage in the coronary arteries is sustained for long enough without intervention, the reduction in blood flow and oxygen supply to the heart will result in myocardial necrosis of the heart and ultimately the death of John, as his heart function is compromised beyond repair.
Aspirin is to prevent MI in individuals who with previous MI or unstable angina. It is contradicted to the patient who is hypersensitive to drugs and those in J6PD deficiency, bleeding disorders, and SAID-induced sensitivity. It has to be discontinued 5 to 7 days before elective surgery to allow time for production and a release of new platelets. Individuals who are allergic to tartrazine dye do not take aspirin. Monitor older adults closely as they may susceptible to aspirin's toxic effects. Adverse effects are hearing loss, rash, and nausea. Morphine tartrate is for self-pain. It is contradicted to in individuals hypersensitive to drug and in those with conditions which preclude opioid administration by IV route. There is extreme caution for patients who have hypothyroidism, Addison's disease, and uterine stricture. Old and weak people also need more caution. Nurses need to advise patients to avoid alcohol and activities that need more mental alertness. And nurses monitor circulatory, respiratory, bladder and bowel function carefully. Side effects are sedation, dizziness, hypotension, vomiting, and urine retention. Metoprolol is to treat hypertension, early intervention in acute MI, and angina pectoris. Nurses will administer this drug later when he is stable. It is contradicted to the patient who is hypersensitive to drugs or other beta blocks, and in those individuals with sinus bradycardia, heart block greater than first degree, cardiogenic shock, or urgent cardiac failure when used to treat hypertension or angina, and the heart rate that less than 45 beats per minute, or the systolic blood pressure which less than 100 millimeter of mercury is also contradicted. On the other hand, used carefully in individuals with heart failure, diabetes, or respiratory or hepatic disease, and in older adults. Nurses always need to monitor apical pulse rates before giving drug and monitor blood pressure frequently. Side effects are hypotension, heart failure, nausea, diarrhea. Lisinopril dehydrate is used to treat hypertension. hemodynamically stable individuals within 24 hours of acute MI to improve survival. Adjunct in heart failure. It is contradicted in individuals hypersensitive to ACE inhibitors and in those with a history of angioedema related to previous treatment with ACE inhibitors. Nurses should often monitor blood pressure, white blood cell with differential counts before therapy every 2 weeks for first 3 months of the therapy. Furthermore, use occasionally in individuals with impaired renal function or at the risk of hypocalcemia, adverse reactions are hypotension and dry, persistent tickling, non-productive cough. Oxygen therapy. Because John has a pulse oximetry reading of less than 94% and present with symptoms of hypoxemia, including shortness of breath and rapid heart rate, a nurse would be apply oxygen therapy for John. A simple face mask would be appropriate for John as a high level of oxygen can be delivered. Oxygen therapy is important for John to aid his breathing and reduce hypoxemia and normalize oxygen levels. And his regular medications is to adjust to diet to reduce low density lipoprotein, total cholesterol, and triglyceride levels in individuals with primary hypercholesterolemia and mixed dyslipidemia.
I'm going to talk about nursing interventions for John. First intervention we are interventing is immediate bed rest. We will require John to be resting in bed as he is tachycardic and lightheaded. Also he is cool, pale and with elevated heart rate. With ECG showing ST elevation, resting will reduce his physical activity and myocardial oxygen demand. He will be in bed until pain-free and stable. We will continue to monitor vital signs as he is in bed. He will require regular and careful assessments of heart rate, blood pressure, respiratory rate, oxygen saturation and temperature. Monitoring fluid volume also important to prevent overloading heart and lungs. We will ask John to sit upright and breathe deeply as he is showing shortness of breath. As the oxygen saturation level is at 93%, we will start the oxygen therapy on face mask. In this situation, we will continue to monitor vital signs every 15 minutes. Generally, it shouldn't be left longer than 30 minutes. We can do it for only once John is stable. Then ECG monitoring. We will continue ECG monitoring on 3-lead ECG to detect evolving infarctions. Life-threatening rhythms such as ventricular tachycardia and ventricular fibrillation and asystole are common in John's presenting symptoms. Therefore, continuous cardiac monitoring is important. The next nursing intervention is the communication. Reassurance and clear communication is vital in John's condition. John could be anxious about his situation and hospitalization. It is important to reassure him to provide autonomy and partnership with other healthcare professionals involved. Communication also plays a huge role as nurses, as we require to explain the procedures and answer any questions the family may have. It is is also important to be assertive in communication as the family might interfere with his care. Other healthcare professionals such as doctors, dietitians and pathology workers is necessary to manage John's situation, so documentation and communication with them is necessary as well. The next intervention is pain management. It is important to do pain assessment with vital signs and keep the pain managed. Analgesia to be administered as prescribed and documented accordingly. Before and after analgesia, pain assessment to be completed to see the effectivity of drug. John will be monitored for any discomfort, agitation, or irritation as verbal and visual assessment. Both anxiety and pain stimulate the sympathetic nervous responses, causing vasoconstriction, increased venous return, and increased myocardial workload. We are using PQRST model to do the pain assessment. PQRST stands for what provokes the pain, what is the quality of the pain, does the pain radiate, what is the severity of the pain, and what is the timing of the pain. As John has 7 out of 10 pain and radiating, he will be administered analgesia.
Patient education is important for John's recovery. This can avoid hospital readmission and reduce the modified risk factors. John's education should include him and his family members as well. Cessation of smoking is the most important secondary prevention strategies for cardiovascular disease. As nurses, we need to encourage John to quit smoking and educate him on the negative effect of smoking on his health. John should be advised that different ways can help him to quit smoking, such as counseling, support group, consistent motivation, and reinforcement messages. As nurses, we should monitor John's diet, refer to dietitians, as eating a low cholesterol, low salt diet can help to reduce his cholesterol level and have a positive effect on the disease progression. Studies revealed that patients who followed the healthy dietary pattern have a 50% to 70% lower risk of recurrent heart disease events. Regular and moderate physical activity could contribute to improvements in cardiovascular health. It can help John to increase the high-density lipoprotein levels and decrease thyroglobulin levels. As nurses, we need to help John to set a goal for physical activity. The goal amount for the average person is a total of 30 minutes of moderate physical activity every day for at least 5 days per week. John can start with 10 minutes per day and then build up over time. We should inform John to stop activity if he develops the symptoms of shortness of breath, chest pain, nausea, or dizziness. And discharge preparation need to include medication review, education about lifestyle modification, referral for cardiac rehabilitation, and a clear follow-up appointments with his cardiologist and primary health physician. In addition, it is crucial to provide education for John about the medications to ensure adherence. Whilst all of the National Safety of Quality Health Services standards would need to accurately be implied in the care of John, there are a few that stand out in this case. Preventing and controlling healthcare-associated infections is important in the nursing management of John to ensure he doesn't acquire a preventable healthcare-related infection that would cause detriment to his recovery. Some methods to ensure this include regular hand washing and the use of aseptic technique. And medication safety is in place to ensure that John is administered accurate and appropriate medication by capable doctors and nurses. This is put in place through government system for medication. Accurate documentation, comprehensive prescribing and delivery process, and continuous medication management. And patient identification and procedure matching is essential to make certain that the correct care, treatment, and medications that are intended for John are delivered to him and not another patient. This is achieved by conforming John's identifier through the approval of 3 patient identifiers when delivering any aspect of care. Finish.